Hey y'all, welcome back, and wanted to spend a little bit of time with you at the top of Module 2, talking a little bit about the class of disorders named schizophrenia spectrum and other psychotic disorders. This is a class of disorders defined by the unifying theme being the presence of psychosis, which is sort of an umbrella term for delusions, which are essentially false beliefs, or hallucinations, which are sort of false sensory perceptions that exist in the absence of some objectively identifiable environmental stimulus. It also involves symptoms such as disorganized thinking, which are typically manifested in speech, grossly disorganized or atypical motor behavior, including catatonia, as well as negative symptoms known as abolition, anhedonia, asociality, and sort of restriction in affect. This class is organized by the complexity and the prognosis of the disorder. So it moves from sort of more simple to complex, sort of good to poor prognosis, which is essentially referring to the level of support required to minimize suffering and support sort of functioning and well-being. It includes, of course, schizophrenia and other psychotic disorders, as well as schizotypal personality disorder. In fact, that's kind of where the class of disorders starts. We will get into schizotypal personality disorder in greater detail when we cover personality disorders later in the term. From schizotypal personality disorder, it moves to delusional disorder, which is a disorder in which psychosis is present in the form of delusions, but the full criteria for schizophrenia have never been met. And aside from the false belief, people with this disorder function reasonably well. They go to work, they go to school, they take care of themselves, they take care of their families, while also dealing with the ramifications of their false belief. From delusional disorder, we move to schizophreniform disorder, which sort of differentiates from delusional disorder and schizophrenia in that other forms of psychosis may be present, but the psychosis and other sort of symptoms of schizophrenia have persisted beyond a month, but have not yet met this 6-month sort of duration standard that is necessary for a diagnosis of schizophrenia. So this is a disorder that may show up in more acute care settings where a person may have been dealing with psychosis for more than a month, but it's relatively early in its manifestation, and the 6-month standard has not yet been met. So just keep that in mind. And then moving from schizophreniform disorder, we move to schizophrenia itself, which requires 2 or more sort of signs of psychosis or disorganized speech, and that these things have persisted beyond 6 months. The active phase may not necessarily last that long, but between the prodromal, active, and residual phases, there's evidence of psychosis, other positive symptoms, and negative symptoms that have persisted beyond 6 months. After schizophrenia, we move to schizoaffective disorder, which is the presence of psychosis along with mood disturbance. So there must be the presence of a depressive and or manic episode, but the psychosis persists independent of the mood disturbance the sort of the depressive and or manic episode. That's what differentiates schizoaffective disorder from a mood disorder with psychotic features. So I think it's important that we spend some time just discussing what psychosis is. And then we'll also kind of get into some of the negative symptoms as well. It's also important to note that these symptoms are very difficult to really personalize by just talking about them. So in addition to this video, I have included in this content folder and this specific item in Blackboard access to a Frontline episode. For those of you who are not familiar, Frontline is a public broadcasting sort of documentary series. This one in particular is entitled The Right to Fail, which covers sort of systemic issues in the care of people with severe mental illness, primarily schizophrenia, in the New York state sort of care system. And it involves essentially it personalizes multiple people with severe mental illness, in particular schizophrenia. I have included sort of in the notes setting up the video of the Frontline episode, sort of time points to pay particular attention to. I recommend that you watch the entire film, but I also recognize that you have other responsibilities, and so you're not required to watch the full film. You really aren't required to watch the thing at all, but I would want you to pay attention to, in the event that you can't watch the full hour, pay attention to the sort of the time nuggets that I've put with it to get a sense of what sort of disorganized speech looks like, or sounds like, appears like, other types of sort of psychomotor agitation, as well as negative symptoms, in particular avolition. So, with that being said, what is psychosis? So, according to the National Institutes for Mental Health, the word psychosis is used to describe conditions that affect the mind where there has been some loss of contact with reality. Now, like I mentioned before, this is not sort of a subjective reality. This is what's being referred to here as an objective reality that is often coupled with sort of observable stimuli in the environment. So when someone becomes ill in this way, it's called a psychotic episode. And during a period of psychosis, a person's thoughts and perceptions are disturbed, and the individual may have difficulty understanding what is real and what is not. Symptoms of psychosis include delusions or false beliefs and hallucinations. Again, these are sort of false sensory perceptions, whether they be visual, auditory, gustatory, olfactory, or tactile. And other symptoms include incoherent or nonsense speech, behavior that is inappropriate for the situation. A person in a psychotic episode may also experience depression, anxiety, sleep problems, social withdrawal, lack of motivation, and difficulty functioning overall. There are, when it comes to delusions, typically themes that go along with the delusion. So, again, these are false personal beliefs that are consistently held despite evidence or logic, lack of insight to the errancy of the beliefs is quite common. The typical themes for delusions include delusions of grandeur, control, thought broadcasting, thought withdrawal, persecution, and delusions of reference. So while delusions of grandeur, control, and persecution may be sort of self-explanatory. So delusions of grandeur, you have sort of an inflated sense of yourself, a grandiose sense of self. sort of control delusions, that you believe someone is, or something, some entity is controlling thoughts and behaviors. Thought broadcasting is the belief that your thoughts are being sort of broadcasted outside of you to others. Other people can essentially read your mind. Thought withdrawal is that some force is taking thoughts out of your mind. Persecution is sort of a delusion that some harm is likely to come to you. And then a delusion of reference is the belief that unrelated occurrences in the external world have a special significance for the person who is suffering from the delusion. So an example of this might be that someone watches a movie and believes that there is a message embedded in the movie specifically for them. And it makes some kind of sense to them. Oftentimes these delusions are coupled with sort of paranoid thinking. So you've heard of the term paranoid schizophrenia. That's what this is referring to. This paranoia is often coupled with persecutory delusions. Hallucinations, on the other hand, are perceptions of a non-existent sort of stimulus in the environment. They could be auditory, so essentially hearing voices. This is the most common form of hallucination. You may also see things that are not in the environment. Again, olfactory is smelling, tactile is feeling on the skin, and then gustatory is sort of tasting things that are absent in the environment. And so those are sort of the descriptions of the two types of psychosis. Along with these symptoms include cognitive symptoms, such as disorganized thinking, communication, and speech. These are quite common characteristics of schizophrenia. There may also be sort of the loosening of associations, or some people refer to this as cognitive slippage. This is continually shifting from topic to topic without apparent logical or meaningful connection between thoughts. And then there's also sort of over-inclusiveness, so there may be sort of a abnormal categorization of ideas or phenomena that is sort of a sign of cognitive difficulties. There also may be lapses in memory and things of that nature. There's also sort of grossly disorganized or atypical psychomotor behavior. This is particularly sort of true in the symptoms of catatonia. So this is, you can have excited catatonia and withdrawn catatonia. These are sort of peculiar body movements and postures. May also include sort of loud and inappropriate laughter. So catatonia is a psychomotor syndrome that has been reported to occur in more than 10% of patients with acute psychiatric illness. So if a person has a psychiatric illness, it is pretty common that they may also experience catatonia. There are, as I mentioned, two subtypes. So the catatonia of the sort of withdrawn, slowed down type. People may have used the term in the past, the retarded type. So obviously that word has sort of come out of the typical language, but you may see it in clinical writings still these days. And this type of catatonia is characterized by immobility, mutism, sort of staring into space, rigidity in the body, and a host of other clinical signs. You may also read about sort of waxy flexibility. So what that is a type of catatonia where a person is sort of fixed in space, but they are not rigid. So, for example, you may come across somebody who's sort of fixed in space, but you can move their limbs, and that limb will stay in the position that you move it to. So that's sort of a explanation of waxy flexibility. Excited catatonia is less common, and it sort of shows up as patients developing prolonged periods of psychomotor agitation. So you may notice that, at least in one of the time nuggets that I provide for you in the Frontline documentary, one of the characters, Nestor Bunch, has some psychomotor agitation going on with his eyes, and that sort of is an example of excited catatonia. So this could be, is not necessarily present, but could be present with a person with schizophrenia. The negative symptoms also are quite difficult to sort of articulate and personalize without sort of witnessing it happening. Again, these include abolition, which is sort of the inability to take action or become goal-oriented. I think you will see this manifested in the character of Abraham Clemente in the Frontline documentary. There's also alogia, which is sort of the lack of meaningful speech. Keep in mind, this is not the same as disorganized speech. Disorganized speech is sort of the presence of attempts to communicate that are disorganized. There's not sort of a logical sort of thread that goes through them. Again, you will see an example of this from Mr. Bunch in the documentary. But alogia is sort of a lack of speech, so lack of attempts to get messages across via spoken language. There's also asociality, which is sort of minimal or no interest in social relationships or support. I think you'll find this showing up in Mr. Clemente as well. And then there's anhedonia, which is the reduced ability to experience pleasure. There's also, as I mentioned before, restricted affects with diminished emotional expression, facial expressions, voice intonation, gestures. Again, you will see this manifested, I think, in Mr. Clemente in a brief sort of clip that involves him. It should be noted that approximately 15 to 25% of individuals with schizophrenia, so a minority, but it's a significant minority. These folks are people who display primarily negative symptoms. So it's possible that the negative symptoms predominate when a person is dealing with schizophrenia. There's also a high incidence of lack of insight and or awareness of psychotic symptoms with individuals with schizophrenia. And so there's the highest lack of awareness when it comes to asociality. And then it kind of goes down to sort of the next most lack of awareness comes with signs of or symptoms of delusion, then restricted affect. People are maybe unaware of hallucinations, but they are more aware that they are having hallucinations than they might be lacking awareness of delusions. And they also, when it comes to thought disorder, that is the least likely they will have lack of awareness, but lack of insight still may be something that you deal with. So the diagnosis involves at least two, the diagnosis of schizophrenia involves the presence of at least two of the following symptoms: hallucinations, delusions, disorganized speech, gross motor disturbance, or negative symptoms. So you may have negative symptoms and gross motor disturbance and meet criteria for schizophrenia. You may have negative symptoms and delusions, negative symptoms and hallucinations. There must also be a deterioration from a previous level of functioning. That differentiates this from just, at least in part, from just delusional disorder. The lifetime prevalence, at one time it was thought to be about 1%, but as you'll see in your DSM-5-TR, it's about 0.3 to 0.7% of the population. Many show impairment in pre-morbid functioning, so the abnormalities exist prior to major symptom onset. This is quite common especially for young people who have experienced maltreatment or chronic bullying. In fact, the experience of chronic bullying is the strongest predictor of the manifestation of psychotic symptoms later in life. And these symptoms typically begin to manifest later in adolescence, so that 18 to 25-year-old range. It's also important to note that most people show improvement over time. So the prognosis is not, all that dire. we'll talk a little bit more some of the predictors of positive prognosis. I mentioned that there are essentially 3 phases of schizophrenia. The prodromal phase is sort of the onset and buildup of symptoms that may include social withdrawal and isolation, inappropriate or sort of restricted affect, poor communication patterns, and neglect of personal grooming. You'll see some manifestation of this in the video. The active phase is sort of the phase in which the person is experiencing their psychotic episode in its full form, the hallucinations, delusions, as well as the other positive and negative symptoms are active. And then the residual phase, the symptoms are no longer prominent, but there sort of is that there is evidence, maybe it's with self-care, maybe it's with sort of social withdrawal, other negative symptoms. They are no longer prominent, but there's still evidence that they have not completely resolved. And there are factors that are influencing recovery include sort of factors that are associated with sex assigned at birth. So women or people that are born female at birth typically have better outcomes if a person has a higher level of education, if they are married or partnered over the long term, they had higher premorbid level of functioning, if there is early intervention during the course of the illness, if they have peer support, and if they have work opportunities, their prognosis for recovery is stronger when they have schizophrenia. Again, schizophrenia is best understood to be the integration of genetic or hereditary factors, psychological characteristics, cognitive processes, and social adversities. So even though it has a very strong genetic component, that is not, it should not be considered to be strictly a biological phenomenon. There may be sort of a strong genetic predisposition, but there also needs to be sort of catalysts in the environment for schizophrenia to truly develop. And each of these dimensions I just mentioned, the heredity, psychological characteristics, cognitive processes, and social adversities, they all interact with each other to lead to this manifestation of symptoms. As I mentioned, strong genetic component. So through twin studies, especially with monozygotic twins, if one twin develops schizophrenia or other psychotic symptoms, there's a 50% chance that their twin will also develop these symptoms. And then if there is a child of 2 parents affected by schizophrenia, they are also not quite 50%, but in the 40% range, likely to develop the symptoms as well. And then there are a variety of other factors, such as dizygotic twins are still highly likely to develop symptoms, but if one twin has it, then only about not quite 20% chance the other twin will develop them. And this is also sort of the similar prognosis, or at least incidence risk if one parent has the disorder. So all that to say, this has the potential to be a very severe and impactful series of symptoms. Clinicians are likely to see this more often in acute care settings, or at least highly supported care settings. But you may, as an outpatient clinician, you still may run into it. If you are working in a college or university setting, you also may run into this because this is around the time, especially for undergraduates, around the time that symptoms begin to start manifesting. And so, if you're working in a university setting, or you may be on the front lines of recognizing the development of psychotic symptoms that will then lead to a diagnosis of schizophrenia. Obviously, you'll be able to read in greater detail about the neurobiology and the medical intervention of schizophrenia in your Ingersoll text. There are close associations identified between dopamine levels and the manifestation of psychotic symptoms. So schizophrenia may result from excess dopamine activity in certain brain areas. This also sort of helps explain potentially the link between cannabis use and psychosis. So cannabis use is particularly the THC that is sort of the psychoactive element of cannabis or marijuana appears to increase the chance of developing psychotic disorder. The higher the intake, the greater the likelihood of psychotic symptoms. Cannabis may influence dopamine levels, especially the THC, and individuals may use cannabis to self-medicate. So there also could be like this chicken and egg sort of relationship between the use of marijuana and schizophrenia. So, people may be developing psychotic symptoms, but then use marijuana to self-medicate and ease their suffering. So it may not be necessarily causative. And individuals predisposed to psychosis may also be predisposed to cannabis use. Other important psychological factors related to schizophrenia may be deficits in empathy, which is related, of course, to deficits in theory of mind, or being able to recognize that others may have different emotions, beliefs, or desires, being able to put yourself in someone else's shoes. There's also an association between early developmental delay and schizophrenia. So, for example, low cognitive ability test scores in childhood and adolescence may be predictive of the development of schizophrenia later in life. So I'm really interested to hear about your questions. I'd love to provide support for clarity. I think in the interest of brevity of this video, I'm going to stop here, and I look forward to seeing what you have to say, what questions you have, what points of clarity you need in the discussion board related to this this module, this at least part of the module. So I'll look for further contact with you and support at that point. And of course, if you would feel more comfortable discussing things in more private sort of environs, please feel free to email me. Yeah, I look forward to seeing what unfolds next. See you in the next video about dissociative disorders. Hope you're having a great day.